Today we're going to talk about the corneal diseases. So what is cornea and what are the pathologies that can occur in this structure is quite interesting. Cornea basically comprises of the 1/6 of the fibrous protective covering of the eyeball. It is placed anteriorly. It is a transparent and avascular structure that is located slightly anterior to the iris. Now there are these peculiar anatomical features which are related to the applied anatomy of the cornea, and we should know and we should well verse ourselves with these anatomical features, because any pathologies that can occur due to these features that can finally result in the pathologies of the corneal structures. So we would be first of all giving you an overview or summarizing the applied anatomy of the cornea, and then finally we'll be going through the congenital as well as some of the quite common acquired conditions that can occur in the corneal structures. So the congenital anomalies are there's a variety of congenital anomalies that can occur in the cornea. For these congenital anomalies, one should know how do you differentiate between a normal cornea and a pathological cornea. Cornea is transparent. It is an avascular structure. So if there is any scarring or if you note down any opacity that is placed inside the cornea, that will be regarded as a pathology, and you would basically note it down. The anatomical features are quite distinct. It is a radial structure. We have a limbal cornea, which has its different pathological features, and then we have the central cornea, and one should know the thickness of these corneal elements as well as the refractive indices of these corneal elements, because that is how the rays of light, they enter and they pass through the lens, and there is a final imaging of any object which is placed on the retina of an individual. So if there is any opacity or if there is any hindrance to pass on these lights from the cornea, that will basically result in the effect which will be placed on the visual acuity of the individual. We should also know that there are particular histological features of the cornea. These layers are quite well important. As well, when we were studying the retina, we discussed the different histological layers of the retina and what pathologies can go wrong in this kind of the retinal structures. So same is the case over here. We should know the histological features of the cornea as well. The cornea, first of all, has an epithelium that is placed anteriorly. When we talk about the histological layers, we always start from the anterior towards the posterior. So most anteriorly, we have the epithelium. The type of epithelium over here is the stratified squamous epithelium that is residing over here. And after that, we have a layer of tight junctional columnar epithelium. Now, there are these particular features and the functions of this kind of columnar epithelium which has tight junctions, and that is basically going to give the protective mechanisms towards the cornea. Again, once we have finished off with the epithelium, we have a feature which is known as Bowman's capsule. As we further go on in this lecture, I'll be just giving you the details regarding what can go wrong in the Bowman's capsule. The particular features of the Bowman's capsule are that it cannot regenerate, and if there is any scarring that takes place at this level of the Bowman's capsule, that would be a permanent scar because it has no quality of regeneration over there. After the basement membrane or after the Bowman's capsule, we have the stromal layer. Now, the stromal layer is basically compromising of the lymphocytes, first of all. Then we have the connective tissue and we have the connective fibrils that are lying inside this stromal layer, or which can also be regarded as the substantia propria of the cornea. After the substantia propria, we have the decimus membrane, which is basically a pre-decimus membrane, and then we have the decimus membrane. The decimus membrane is basically quite a tough layer which is present right there. So this toughness basically provides another protection, and it gives out the thickness to the cornea, as well as the protective functions are also encompassed over here. After the basement membrane and after the decimus membrane, we have the endothelial layer of the cornea. So you have to remember these histological layers because they have their own functionalities. They perform their own functions and they give basically the transparency to the cornea. The congenital features, if we talk about them, we have the megalocornea on one hand. Now, what basically happens is if there is a cornea which is more than 13 millimeters in diameter for about the first 2 years of life, at the age of 2 years of the baby, then that would be regarded as the condition which is known as megalocornea. It has its own prefaces for that. The child would usually present with irritation, as well as sometimes there would be inflammation that would be residing in the cornea, as well as there would be slight proptosis, which is noted down by the parents, of course. So you have to basically measure whether the child is suffering from some sort of a condition, because usually this megalocornea, it presents with ophthalmos, or either the child is suffering from a condition which is known as keratoglobus. So these are the usual conditions that the child is suffering from, and you basically measure the size of cornea and assess whether this child has some sort of a megalocornea or not. The main function of the cornea is to transmit the images to the retina for the final imaging that would take place over there. So if there is any feature that is basically hindering this function, that will result the final imaging that is taking place at the retina, and obviously the visual acuity of the individual that is going to be also affected in this case. So in these cases of megalocornea, the features that are particularly noticeable, the signs and symptoms that are particularly noticeable over here are the horizontal cornea. The diameter is almost 13 millimeters or greater over here. The normal diameter of the cornea, I would like you to appreciate over here, is almost 11 meters in a normal individual at the age of 2 years. So you have to basically have this comparison in your mind whenever you are diagnosing a particular individual that he or she is suffering from megalocornea. The cornea is usually clear. There is a normal thickness and vision that is also seen in these individuals. The condition is not progressive at all because there is no opacity, of course, that is seen in this individual. There's just a slight diameter changes that are observed. Usually, this kind of a condition is associated with a syndrome. For example, the child may be suffering from Marfan syndrome, Apert syndrome, Down syndrome. These are the particular syndromic condition that the child may be suffering from. So, if you diagnose someone to be suffering from megalocornea, you should further investigate him or her if he or she, the child, is suffering from some sort of a syndrome or not, because the condition itself is not progressive and the condition itself is not going to hinder the visual acuity of the individual in any case. There are these systemic associations with this condition which is known as megalocornea. You usually see that the child may be suffering from Marfan's and Apert syndrome, as well as it can be the Down syndrome, it can be the Ehlers-Danlos syndrome, or either the child is suffering from Down syndrome. So you have to investigate the patient in detail, whether he or she is suffering from some sort of other delay in the milestones, and either there are any other developmental delays that are noted down in this particular child. The IQ is noted down, and all of these features basically correlate with each other, and then you can have a definitive diagnosis in this particular patient. The differential diagnosis of megalocornea can also include ophthalmos or either. The HABs striae and raised intraocular pressures are basically the features that are associated with ophthalmos. On the other hand, we have keratoglobus, which is basically the thinning and the protrusion of the cornea, which can take place in these individuals who are suffering from this kind of a congenital condition in these babies, which is noted down. On one hand, when we have discussed a condition which is known as megalocornea, we have the other side that is basically known as microcornea. As the name is suggesting, the myoments over here would be less than 10 millimeters of the diameter of the cornea in these individuals. The horizontal diameter is less than 10 millimeters since birth. That may occur as an isolated anomaly, which is quite rare. Usually, again, this condition would be associated with a lot of syndromic conditions in association with nano and microphthalmos. So usually it is not just the cornea, it is usually associated with the diameters of the orbit on a whole. There would be a microphthalmos that would be also noted down in these babies. Then when we are discussing megalocornea or microcornea, that is basically suggestive of the fact that the diameters of the cornea are variable. Then we have cornea plana. The associations over here usually that are associated with a microcornea. The anomalies are quite rare and usually that is bilaterally placed and the cornea is quite flat in these individuals. The result that would be produced due to this flat cornea, it results in marked astigmatism and refractive errors, of course. The main function of the cornea, as I've been possibly telling you, that it is to basically give the refractive index to the eye, and if this particular kind of a refractive index that is not in a proper manner, then the child may be suffering from myopia, hypermetropia, or either astigmatism. In this particular case, the child would be suffering from astigmatism if the child has a flat cornea. When there are basically the pathologies that are related to the size of the cornea, the more pathognomic pathologies are the transparency of the cornea. One of the very important features of the cornea is that it is avascular as well as it is transparent. Now, there are these particular features which contribute towards the transparency of the cornea. That would basically include the avascularity. 78% of cornea is made up of water, as well as the Morris's theory of the lattice work that is found at the fibril level that is contributing towards the transparency of the cornea. And obviously, lastly, we have this particular refractive index that contributes towards the transparency of the cornea as well. So in some anomalies, in some pathologies, we usually observe that this cornea doesn't remain transparent, and so it is going to hinder the visual acuity, whatever the pathology may be. It is going to finally result in the hindrance of the visual acuity or decrease the visual acuity to quite a marked level. The conditions that usually present to you in the outpatient departments and in which that would be basically the differential diagnosis in which you observe the haziness of the cornea, there is an opacity in the cornea, or either you can also term it as the cloudiness of the cornea that is observed in these patients. There would be usually this condition which is known as anterior and posterior embryotoxon. Then the congenital corneal opacities that are sometimes present, they can be due to a lot of reasons. They can be due to infections or either the trauma that occurs during birth. Then the child may also present to you with sclerocornea, which is also regarded as a cloudy cornea observed in the infants. The dermoids sometimes occur at the inferotemporal limbus. So this is the most important location of the dermoid. We usually find these dermoids in the cornea at the infero as well as at the temporal side of the cornea. So it's not located medially, rather it is located laterally. This opacity of the cornea is usually found. The differential diagnosis is quite interesting. Whenever you come across this cloudiness of the cornea, what are the differential diagnoses? It usually has the mnemonic, which is termed as STUMPED. The S stands over here for the sclerocornea. The T stands for the tears in the Descemet's membrane. We have the U, which stands for the ulceration. So we can have the keratitis, which finally results in the ulceration of the cornea, and that would again result in the haziness of the cornea, or either, which is also regarded as the cloudiness of the cornea. The M stands for metabolic conditions. We have the P, which stands for the posterior corneal defects. The E stands for the endothelial dystrophies. And finally, we have the D, which stands for the dermoidal lesion. So this is a kind of an interesting mnemonic by which you can remember whenever you'll come across a patient who is suffering from a cloudy cornea, this word stumped would be kept in your mind, and you can get the differential diagnosis in your head quite clear that these are the conditions that this child or this person can be suffering from. And then that would be quite easy. When you investigate the case, you can just finally come outcome whether the child has been suffering from some sort of infections which led to the corneal ulcerations or the perforations, or was it a congenital condition. Again, to get to the definitive diagnosis in this case, you would have to take the history in detail and quite accurately to get to a final diagnosis, in this case of a cloudy cornea. A very common condition that we usually come across relating to the cornea is the ulcerative keratitis. Keratitis is a word that is given to the corneal inflammations. So there are different etiologies, different pathologies, and different ways for classifying these conditions, which is known as the ulcerative keratitis. It can be according to the location, whether it is located at the limbal margin, whether it is located centrally. It can be also related to the signs and symptoms. For example, keratitis, which is associated with sloughing. Keratitis, either it is associated with perforation, keratitis associated with hypopyon. So these are the important terminologies that you have to keep in mind. The sloughing, hypopyon formation, congestion, perforations, these are the basic complications of the keratitis or the ulcerative purposes, and this makes one way to classify keratitis clinically when you have a patient of ulcerative keratitis. One of the ways to classify ulcerative keratitis is also through the etiologies. We can have an infective keratitis, as you can see over here. On the other hand, we can have the traumatic keratitis, the autoimmune related, the systemic diseases usually result in a particular kind of keratitis. So these are basically the ways how you classify the keratitis, either on the clinical basis, or you can also classify keratitis on the etiological basis. When we talk about infective keratitis, there is a subclassification to this category. Infective keratitis can either be a bacterial origin, we can have a viral origin, the mycotic or the fungal origin, and then we have the autoimmune, that is the inflammatory keratitis, it can also occur. So these are the different forms in which the infective keratitis can also occur. Now, the bacterial corneal ulcers and how do they develop? This is again very important, that how do these corneal ulcers develop in an individual? There is a defensive mechanism. The lysozymes, for example, the beta-lysins and the protective proteins are quite important over here. Then we have the predisposing diseases, for example, some local ocular predisposing diseases, they are quite important. And finally, we have the ulcer development. So a child or a person should be predisposed to the development of this kind of a bacterial corneal ulcers. That means that his or her immunity has to be decreased to get on or to hold on to this bacterial corneal ulceration. The ulcer development would then finally take place. The weak host immunity is very important, as well as the virulent microbe. So sometimes the Streptococcus pneumoniae, the Staphylococcus aureus, the chlamydial pneumoniae, these are all of the organisms that can contribute towards the development of corneal ulcerations, that is the bacterial origin ulcerations in an individual. So either the individual has a weak immunity, or either the host is the virulent is basically, the microbe is quite virulent over here. So these are the two reasons that can complicate the situation furthermore for that individual. The etiologies over here would consist of the corneal epithelial damage that can occur. The epithelial damage, it occurs due to the corneal aberrations, due to the small foreign bodies that are misdirected. Cilias can even contribute towards the irritative factors, as well as epithelial drying phenomena, as in xerosis and exposure keratitis. The necrosis of epithelium can occur, as in cases of keratomalacia, as well as the desquamation of the epithelial cells as a result of corneal edema. So these are the particular reasons for the development of the corneal damage. Once the corneal damage has occurred and the initial protective layers has been removed, the cornea is basically exposed to the bacterial infections in the environment. The sources of infection over here can be an exogenous source, or either it can be from an ocular tissue or the neighboring structures. The infected foreign bodies and the vegetative material, it's one of the source of the infections in the individuals. Then we have the conjunctival sac or the lacrimal sac. It can be one of the reasons, one of the exogenous reasons to hinder off this kind of keratitis in the individuals. The diseases of the conjunctiva, they readily spread in these patients, or those of the sclera to stroma. So these are some of the ocular tissues that can contribute towards the ulcerative keratitis, as well as infections can also travel from the uveal tract towards the cornea. So these are the sources of infections, and then finally the causative organisms. We know what are the sources of infections, so we should also go through the causative organisms as well. The range of causative organisms would consist of the gram-positive cocci, that basically consist of the Streptococcus pneumoniae or the Staphylococcus aureus. These are the commonest organisms. We have the gram-positive bacilli as well. Finally, we have the chlamydial organisms in the gram-positive filamentous bacteria. And we have the mycobacteria as well, which can contribute towards the development of ulcerative keratitis. We have the gram-negative rods, and we have the gram-negative cocci as well. So these are the groups. As you can see, it is a vast variety of organisms that can cause the ulcerative colitis in these individuals. The pathogenesis, the stages that you can appreciate clinically are very important. First of all, there would be a stage of infiltration. Obviously, whenever there is an infective process that is going on, there would be this stage of infiltration that would consist of the lymphocytes, the monocytes that would infiltrate into the area that is finally infected by any organism. After that, there would be a stage of active ulceration. So if there is a damage to the Bowman's capsule, or if there is a damage that can go on to the substantia propria, that would basically give the breach in the epithelium, and this breach in the epithelium is obviously known as an active ulcer that is being formed in this patient. Finally, there would be a stage of regression. If the stromal elements are not involved in this particular case, or the Descemet's membrane is not involved, that would basically give way to a self-healing process that starts on, and that would be basically the stage of regression. The healing is basically known as the stage of regression. After on, then the patient would be in a stage of cicatrization. There would be this, the ulceration is basically healed upon, and that would give out a final picture of a scarring sometimes that would be seen in these patients. That is known as the stage of scarring or the stage of cicatrization. The localized corneal ulcers that you usually observe and what are the different stages of the pathologies over here, as we've already discussed, there is a stage of inflammation. That is the first stage or first pathological stage over here. Stage of progressive infiltration that you can appreciate over here. And then finally, when there would be a breach in the epithelium that is observed quite significantly over here, that is known as the stage of ulceration in these patients. That is the active ulceration which starts on from here. After that, there would be a stage of regression when the active inflammation has stopped and there would be the start of the healing process basically. The fourth and the final stage would be the stage of cicatrization, which is also known as the stage of scarring in these patients. So these would be the pathological steps or the clinical steps for the formation of the infective keratitis, mostly the bacterial keratitis. We usually observe these kind of pathologies in the patients. Then there can be some sort of complications which we also observe in these patients. Dysmetascele is one of the complications. This is a diagrammatic representation of dysmetascele. What basically happens over here is whenever there is a breach or whenever there is a breach in the epithelium, the ulcer that reaches the Descemet's membrane. Now, Descemet's membrane, if it's not perforated, it's quite a tough membrane and it protrudes out. That is basically pushed outwards. And you can even observe over here the protrusion can be observed in the eye outside the ulcer or inside the ulcer. You can observe that the Descemet's membrane that is protruding out, this is known as the dysmetascele. This is one of the complications. It's basically the indication for surgery as well. So whenever you have this sign and you observe this sign in the individuals, that is one of the indication for the surgical procedures to be carried out. Then the perforated corneal ulcers with the prolapse of the iris, that can also occur. It's again one of the complications. If the Descemet's membrane, it's also been exposed or it's also been perforated, then finally there would be the prolapse of the iris that can be observed clinically as well in the patient. The ulcerative process, it deepens and it reaches the Descemet's membrane in the individual. After the perforation, the aqueous escapes and the intraocular pressure falls because once the perforation has taken place, before that, there would be a condition of increased intraocular pressure in cases of ulcerative keratitis when the perforation is small and opposite to the iris tissue. So these are some of the complications after the perforation has taken place. The whole cornea, it sloughs off and there is a total prolapse of the iris. So once there is this perforation, there is this sloughing phenomena. We are basically moving on to another complicated state of the corneal ulcerations. The iris is inflamed, the exudate, it is blocked, and the pupil, it basically has the false covering, which is also known as the pseudocornea in this kind of individuals. The formation of the thin pseudocornea is by the exudate. So it's not actually the cornea, it's just a fake cornea due to the accumulation of the exudates locally over the tissue. This ectatic cicatrix is called as the staphyloma. So once we have one of the complications that we have to keep in mind, it's called as the dysmetascele. The second complication that we have come across, it's known as the appearance of the staphyloma. It's basically the collection of all of the inflammatory tissues after the perforation has taken place. This staphyloma formation or this anterior staphyloma can be observed in the patients as well. Now, the sloughing of the corneal ulcers, this is how it looks. This is how the anterior staphyloma presents to you clinically. Whole of this iris and whole of this cornea is basically sloughed off, and you have a pseudocornea that is basically covering the iris and the eyeball. So this is the particular kind of a picture, and it's basically a complicated case of corneal ulceration. The clinical features for the corneal ulcer that you'd be looking for are the hypopyon ulcer that you would be also looking for in this kind of patients. There would be a foreign body sensation that the patient would complain of. The patient would also complain of photophobia, that is the inability to tolerate light and watering, as well as the patient would complain of a blurred vision. So these are the symptoms mostly. Hypopyon ulcer is the only sign that the clinician could observe, or either he could observe the collection of the anterior staphyloma or either the desmatocele if it is a complicated case of the corneal ulcerations. The redness of the eyes, they are observed by the clinician. Then the clinician can also go along and observe the swelling of the lids. Along with that, the patient might be suffering from blepharospasm, or either it can be the chemosed conjunctiva that the patient is suffering from. The characteristic features for the corneal ulcerations would be the Staphylococcus aureus, or if it is caused by the Staphylococcus pneumoniae, then there would be an oval, yellowish, white, opaque ulcer. So these are the characteristic features depending upon the causative organisms. Again, one of the ways when you haven't sent any of the histopathologies and you haven't basically sent for the culture phenomena and you still want to know what are the organisms involved, the Pseudomonas species, they give an irregular sharp ulcers as well as a diffuse liquefactive necrosis that is also noted down in these kind of infections. In case the infection is caused by the Enterobacteriae, there would be a shallow ulcer, grayish-white, or a pleomorphic separation is also noted down in these kind of infectious states. The characteristic features over here would consist of an oval ulcer that is seen, and then there can be a ring-shaped ulcer. So this classification depends upon the type of the shape. It is regardless of the fact what are the causative organisms or what are the complications that are associated with it. Then finally, the clinical features that you would be observing as an ophthalmologist or as a general physician, you would be looking for the hypopyon. Hypopyon is basically the anterior chamber may or may not show hypopyon, but you still have to look for these signs. This is basically the collection of the exudates and it's basically collected in the inferior lateral or inferior medial margins of the cornea due to the gravitational forces in action. So iris may be slightly muddy as well. The pupils may be small due to the iritis, and the intraocular pressure may be raised due to inflammatory glaucoma, but this is only until the perforation occurs. After the perforation, there would be a decrease in the intraocular pressure. Then basically this is the collection of the hypopyon corneal ulceration that you can appreciate over here in this patient. As you can see over here, due to the gravitational forces, this is the collection of the infiltrates in the lower margin of the cornea. And this is one of the signs, or this is one of the one way in which you can basically diagnose that this case is going on into a complicated state, and you have to basically cover the case with systemic antibiotics or some sort of topical antibiotics. Now, the hypopyon corneal ulcers, what are the etiopathogenesis towards it? Usually, if the causative organisms is staphylococci or either it is the streptococci, they usually present with this hypopyon. Then Moraxella. Then we have the gonococcal ulcers, and finally we have the Pseudomonas pyocenia. So these are the organisms which can result in an ulcerative keratitis that is associated with hypopyon collection. The etiopathogenesis towards the hypopyon corneal ulcers would consist of the chronic dacrocystitis that causes the pneumococcal infections. It can be the virulence of the infective organisms as well as it can be the resistance of the tissues. So these can be the features that you have to consider at the back of your mind when you are making the differential diagnosis or even either the definitive diagnosis in these patients. The mechanisms over here would consist of that are associated with summaritis or the outpouring of the leukocytes. The cells will gravitate to the bottom of the anterior chamber to form the hypopyon, and the ulcerative process is controlled. The hypopyon is then absorbed after that. So you need to give some sort of systemic antibiotics, and that would basically result in the self-resolution of the hypopyon in these individuals. The clinical features would consist of this kind of an ulcer serpens. So you have to basically appreciate the fact that the Streptococcus pneumoniae is usually the causative organism in these cases. The violent iridocyclitis is again very important. And then we have a remarkably little pain. The patient would give you a history of pain, infection in the iris, as well as the secondary glaucoma would also be one of the causative factors over here. So these are the usual clinical features that you're going to observe in these patients and note it down or document it down for the further evaluation. The ulcer serpens is basically one of the complicated case of the corneal ulcerations that takes place. The usual causative organism over here in cases of ulcer serpens is the Streptococcus pneumoniae. That is the causative organism in this kind of cases or in this kind of complications over here. The management in cases a hypopyon occurs along with a corneal ulcer. You have to manage the secondary glaucoma by giving off 0.5% timolol maleate. You can also give the BID eye drops along with that. Then we can prescribe the patient with the oral acetazolamide. That is just for the chronic dacryocystitis. We perform the dacryocystectomy procedures. If that is the cause or if that is the major factor that is contributing towards the corneal ulcers, then we have to perform this surgery for the final cure or the final treatment in these patients. Certain complicated states or certain complicated features in cases of corneal ulcerations are the toxic iridocyclitis, that is the infections of the iris as well as the lens can occur, the secondary glaucoma can occur, that is the increase in the intraocular pressure. A dysmetacele, that is the outward protrusion of the Descemet's membrane can occur, as well as corneal scarring results due to the cicatrization process. Finally, if it is left untreated, the patient may also present with the perforation of the corneal ulcers as well. The sequelae of the corneal perforations would consist of the hemorrhages and the iris prolapse can occur. Either the patient may present with the purulent uveitis or endophthalmitis. There would be an anterior capsular cataract, or you can also observe that there is an opacification of the lens that is associated with this kind of an ulcerative keratitis. Finally, there can be a corneal fistula or there can be an inflammation involving the whole of the orbit, which is basically known as panophthalmitis in these patients. How do you evaluate these patients once you have diagnosed that this person or this patient is suffering from an infective keratitis? The evaluation would start off from history taking, as I've already focused on the fact that history is very important, either trauma, either infection, or either it's the lower down immunity of the individual which is resulting in the complicated states that are associated with the ulcerative keratitis. To elicit the mode of onset, we have to take a deep down history of the individual. Once you're done with the history, you'll physically examine the individual as well for the build, for the nourishment, or any sort of anemia, that is the decreased hemoglobin if it can be observed, because all of these factors are going to contribute towards the immunity of the individual as well. Once you are done with the general physical examination, you're going to carry on the ocular examination. There would be a diffuse light bimicroscopic check, a regurgitation test, as well as the syringing is done when you want to perform the ocular examination. Now, why the syringing? Because you want to observe whether there is some sort of a regurgitation that is being held on along with the nasolacrimal duct. That is going to basically be one of the etiological factors, dacryocystitis, which contributes towards the development of corneal ulcerations in the individuals. Then we are going to run down some tests on this particular patients that would consist of the hemoglobin, the TLC, DLC, ESR, basically highlighting any sorts of infectious states. Blood sugar levels, urine and stool tests are performed. Staining is done for the Gram and the Giamza stains, CFW stain, KOH preparations, potassium hydroxide, basically for these particular kind of organisms. Cultures are done on the blood agar, or we also use the Sebord's agar or the dextrose agar for the cultivation of the cultures, and obviously to isolate organisms. The specific treatment would consist of the systemic antibiotics as well as topical antibiotics. They are given to these patients. We give the oral ciprofloxacin, cephalosporin, and aminoglycosides. Hand in hand, we are coupling up the systemic therapy with the topical antibiotics. That would result in the initial and the subsequent therapy. We use a fortified eye drops. Fortified is a word basically when we are coupling these two drugs. We are giving cefalozolin and we are coupling it up with tobramycin. So this is going to be a fortified drug. But this is just an initial treatment. Once we have control of the situation, we're going to stop giving off these fortified eye drops and we'd start off with the normal eye drops. Then we can also give the freshly prepared fortified vancomycin just to have a better coverage in these patients. The non-specific treatment would consist of cycloplegic drugs. Now, we basically mean atropine when we use the word cycloplegic over here. We are going to give the systemic analgesics, the anti-inflammatories, as well as we are going to increase the immunity by giving the multivitamins, for example, the vitamin A and B to the patients. The general Myers would consist of, obviously, the hot fermentation. This is done just to release any sorts of pressures, the dark goggles to cover up the photophobias, good diet to increase the immunity of the individual, fresh air, and good rest. So these are some of the precautions that can be taken down for these individuals, and they present to you with a better outcome after you take all of these general Myers and they're coupled up along with the medical treatment. If the ulcer is not healing, we regard it to be a non-healing corneal ulcer. In this kind of a case, we basically have the removal of any known cause. The mechanical debridement and cauterization is important. Then we are going to give off the bandage, that is, even a soft contact lens can be given to the patient for the protection, as well as the peritomy, which basically means the severing of the vessels. If it is a systemic inflammation, we can sever down the vessels just to hinder down the spread of infections from the neighboring structures as well. If there is an impending perforation, that means that you're suspecting that this kind of the patient is going to go into a perforated case, you're going to ask the patient not to strain. For example, coughing, crying, vomiting, all of these phenomena can further aggravate the situation for these individuals. Acetazolamide is one of the drug of choice over here, and you're going to perform the pressure bandages that are given to the patient, as well as you're going to give the tissue adhesive glues wherever you see this is the corneal ulceration. You're going to perform the adhesive glues over here or the pressure bandages. For that sake, you're going to avoid the perforations which are impending in a patient. Sometimes a conjunctival flap, which is another surgical procedure just to avoid any kind of perforations which are impending in a patient. Now, the bandage are usually soft contact lenses or either the amniotic membrane transplantation. All of these, either it is the bandage or the amniotic membrane or either it is the conjunctival flap, these are basically the ways to hinder down the perforation that is impending. You know that there is a weak wall, there is an ulceration, and you want to strengthen that wall by all of these methods. The penetrating therapeutic keratoplasty, it's one of the ways. Another way to heal down the ulcer in a manner in which perforations are impending. The treatment, if the perforation has taken place still after taking all of these preventive measures, first of all, you're going to prevent perforation, of course, but if it takes place, then what you're going to do, basically, you're going to give the adhesive glues, or either you can perform the surgical procedures to repair the corneal perforations. The conjunctival flaps, they are taken and they are implanted at that place of the perforation. Keratoplasties are also performed. If it is a very minute perforation, you can perform these keratoplasties as well. And you can always give bandages to the patient to have a better outcome or to further expose the cornea towards the spread of infections. Then we have the marginal catarrhal ulcers as well. What is the etiologies towards that? Catarrhal is a word which is indicating it is of an allergic origin. The hypersensitivity to staphylococcal toxins, it can be caused by Moraxella and can also be caused by Haemophilus in a lot of patients. Usually, this condition is associated with blepharoconjunctivitis. The features of this catarrhal kind of ulcers are there's a mild ocular irritation and pain, which is associated with photophobia, intolerance to light, staphylococcal conjunctivitis, or either there can be the vascularization, which occurs quite soon. Watering is one of the clinical features as well. All of these are basically the features of irritation that you usually observe. What would be the treatment that would usually be prescribed to these patients is the topical corticosteroid drops coupled up with antibiotic therapy, as well as the treatment of the deranging blepharitis in these patients and the treatment of conjunctivitis. So if there are any impending neighboring structures which are subjected to infections, you have to treat these infections first of all. Then we have the mycotic corneal ulcers that give you usually a picture like this with a significant hypopyon that is observed in these patients. The etiologies are the filamentous fungi that are usually aspergillus or either the dimorphic fungi that are the Histoplasma coccideus, and sometimes the yeasts are also one of the causative factors, that is the Candida and the Cryptococcus. Most common of all of these is the aspergillus, which is contributing towards the formation of the mycotic corneal ulcers. The modes of infections in this case would be consisting of the injury by the vegetative materials, that is the crop leaf is usually given. Then you would basically have the injury by the animal tail and sometimes the secondary fungal ulcers in the immunosuppressed patient. So sometimes it is the environment, and on the other hand, it is the depressed immunity of the patient himself or herself that contributes towards the development of mycotic ulcerations. You're going to prescribe the patients with the antibiotics as well as the steroids. We can also couple up this therapy with the systemic antibiotics as well as the systemic steroidal therapy. Now, the mycotic corneal ulcerations have their particular clinical features. We have they are sometimes like the bacterial ulcers, sometimes they are dry looking and grayish. They have a big hypopyon, which is associated with this phenomena. An endothelial plaque is associated with it, and the corneal vascularization is also seen along with this kind of the mycotic corneal ulcerations. Of course, you're going to have the differential diagnosis, and then you're going to get to the definitive diagnosis once you grow the cultures. The features would consist of the pigmented ulcer that is usually brownish, a sterile immune ring-like yellowish ulcer is also seen. Then we usually come across multiple small satellite lesions as well. The perforations in the mycotic ulcers are very rare. Until and unless there is a highly decreased immunity in the patient, you won't be seeing these perforations. The diagnosis is the examination of the wet KOH and CFW cultures or the Sabords cultures. The grams and the Giamza stains are filmed for the fungal hyphae. And then finally, you're going to have the confocal microscopic examinations, and the PCRs are also performed just to have a definitive diagnosis. The treatment would consist of the natamycin and nystatin. You would prescribe the patient for intrachemal or intracorneal voriconazole. The systemic antifungal drugs are also prescribed. Along with that, we give off the advice of a penetrating keratoplasty if it is indicated in the uncomplicated cases as well. The non-specific treatment would consist of which is quite similar to the bacterial corneal ulcerations. You would give off the systemic antibiotics coupled up with the steroidal therapy. So over here in this lecture, basically, we dealt in with the keratitis, which is a condition of the inflammation and infection which can flare up at the corneal level. How do we diagnose? How do we have a differential for such cases? And how do we get to the differential diagnosis? What are the different complicated stages? One should be well versed with all of these conditions when you're working in your outpatient departments. So that is the end of this lecture. Thank you for watching sqadia.com.